Welcome to the ACP Problem Solving in Oncology webinar series. My name is Dr. Joni Howells, member of the ACP Trainees Committee and Registrar in Medical Oncology at West Wales Cancer Centre, and I'll be chairing this evening's session. This evening's webinar will provide you with an overview of melanoma and non-melanoma skin cancers. The educational content of this evening's meeting are entirely non-promotional, but we are proud to have the webinar series sponsored by SI and Roche, world leaders in oncology pharmaceuticals. Our webinars are recorded and will be made available on the EBN Health ACP Library website within a couple of weeks. This is free for all ACP members, and you can also access all the ACP Problem Solving in Oncology book series within the library. I now have the pleasure to welcome and introduce our first speaker of the evening, Dr. Ricky Frazer. Dr. Ricky Frazer is a medical oncology consultant at Velindre Cancer Centre, South Wales. He specialises in renal cell cancer, skin cancer and acute oncology, and is clinical lead for the Acute Oncology Assessment Unit at Velindre Cancer Centre and the Immunotherapy Toxicity Management Services. He has been heavily involved in the development of the National Practical Management of Your Immuno-Oncology Patient educational series. He's been involved with writing national toxicity guidelines, such as UCOM's Acute Oncology Management Guidelines, and has a strong educational interest and is currently a Royal College of Physicians College tutor and faculty lead, as well as honorary lecturer at Cardiff University. Dr. Frazer, when you're ready, over to you. Please go ahead and share your slides.
Fantastic. So it's great to be here. It's always a little bit embarrassing when you get introduced because, you know, it always sounds a little bit more pretentious than reality. So, you know, my name's Ricky. I'm a consultant at Velindre, and as Joni's quite rightly said, I do a few different things. So, jack of all trades and master of none. But this evening, I'm going to talk a little bit about melanoma. Keen that this is, you know, interactive. Here to learn, here to think about cases, and I'm going to pose a few cases as part of it. So do ask. Joe's here as well. Joe is a really good friend and colleague of mine who also treats melanoma. So you've got buy one, get one free this evening. And so again, feel free to ask us anything you like. And thanks for joining. So it's beautiful weather out there. I believe up north, you've had your first sunny day for a long time. So really honoured that you've joined us for an hour tonight. So what we're going to do, we're going to talk a little bit about melanoma. I'm going to talk through some cases. I'm going to pose 3 scenarios, and I'm keen to get some thoughts. Then I'm going to talk a little bit about metastatic management, a little bit about adjuvant management, and then talk a little bit about some of the ongoing dilemmas in melanoma and how we might approach these. And I've got about 20-25 minutes, so this is by no means going to be exhaustive. I'm going to try and cover everything in a little bit of detail, but hopefully leave enough there for us to have some conversation later. So this will be a revision, hopefully. This won't be new to any of you. So, you know, this is just talking about different types of cutaneous melanoma. So we've got superficial spreading, which is the most common that I see in real life clinical practice. We've got nodular, which tends to be a little bit more aggressive. We've got lentigo maligna, and we've got the acral lentiginous. So lentigo tends to be more common in the older patient, and the acral lentiginous tends to be a little bit more common in the Asian community. And as many of you will know, BRAF mutations are the driver for a lot of these cancers, and they occur in about 40% of all the patients we see. And then we've got 2 other types of melanoma, which I'll allude a little bit to in the dilemmas, but again, I've not made the subject of a lot of the talk this evening because, again, time wouldn't really facilitate that. We've got mucosal melanoma, which tends to be on areas like the vulva and internal surfaces. And then we've got ocular melanoma, which frankly is still really challenging to treat. We tend to use similar things to what we used in cutaneous with much more limited responses. And we've got a couple of newer therapies coming through. And again, I'll briefly mention those. And hopefully this will be revision, but I think it's important to remember that we've come a long way. So, you know, if I'd given this talk a few years back, we could have been done in about 10 minutes and you could have gone back and enjoyed that sunshine, because we really had dacarbazine. It was rubbish. It did very little. Responses were 10 or 15%. 2 or 3% got to 5 years, not many at all, and everyone died pretty quickly. And I've just included this picture, and it's really nice when you get asked to give a new talk, because I got to update some slides. And so I quite like this, which showed the progress that we've had in overall survival based on a number of different treatments that we've had. And again, we'll talk a little bit in a second about some of the 6.5-year data, which has got a survival rate approaching 50%. So, you know, exciting in terms of the progress. I guess the flip side, if I'm honest, is that it's a little stagnant at the moment. So lung cancer is clearly having a flourish, as other tumor types. And in melanoma, we haven't had as much progress in the last 2 or 3 years as perhaps we had in the 2 or 3 years before that. So first polling question, and this, I take no responsibility for how the polling bit works. There's a very clever team in the background who are going to do this. So 37-year-old female, all of these are real patients, by the way. So 37-year-old female presented with a relatively early stage melanoma a few years back now. No significant past medical history, a little bit of hypertension, on amlodipine, on surveillance scans, as is fairly routine, presenting with shortness of breath in June, relatively recently. Lung metastases on the CT, and I'm by no means a radiologist, but even I can see those lung metastases. A V600E mutation, which is the most common BRAF mutation we see in clinical practice, and a normal LDH. So the sort of patient that Joe and I would see on a regular basis on our Thursday morning clinic. So how might you approach this case? And I will just, and like magic, we've got some options. So they're BRAF mutated. Would you give dabrafenib and trametinib? Again, another BRAF option. Would you give encorafenib and binimetinib? Would you give combination immunotherapy with ipilimumab and nivolumab, which we've got some really nice long-term data for? Would you go with single-agent pembrolizumab, I guess, based on the fact that this is a relatively low LDH and fairly favourable metastatic lesions? Or would you say, actually, let's give something that's a bit punchier than single-agent PD-L1, but probably not quite as punchy as combination immunotherapy, and give relatlimab and nivolumab based on Relativity 047 trial, and we'll just allude to that later. So let's maybe see if we're ready, what kind of things are coming through. Okay, so that's a really interesting split. I wasn't expecting that split, so that's interesting. No one's going with single agent pembro. I think we'll talk about that. I think a lot of colleagues up and down the country in reality probably would give single agent pembro. Absolutely, combination immunotherapy. Joe and I prescribe a lot of combination immunotherapy. I think that's very reasonable. And actually, you know, half of you would go with targeted therapy, which I think is a very reasonable choice. And we maybe will talk through some of the pros and cons of that based on a couple of recent trials like Dream Sequence and others. But good, okay, so that gives us some things for thought as we go through. Let's pose another scenario then, and I'm just going to let the PowerPoint catch up with us. So 72-year-old man presents generally unwell with abdominal pain. A long time ago had a really early stage melanoma. CT scan shows new lung mets, liver mets, and splenic mets. Again, V600E is the most common type of BRAF melanoma, this time with a raised LDH and a poor performance status, although I have to say this chap was relatively fit 4 weeks before he presented with fairly widespread metastatic disease. And I think that's important, that performance status here is guided by disease, it's not guided by comorbidity. So by magic, we'll get some options. So what would you do? Would you think about best supportive care based on the fact that this is fairly aggressive disease? Splenic mets always worry me when I see them. Would you give dabrafenib and trametinib, again, targeted therapy targeting BRAF? Would you give what I guess we would consider a second generation BRAF treatment with encorafenib and binimetinib? Would you go with combination immunotherapy with ipilimumab and nivolumab? Or this time, would some of you think about single agent in view of a relatively poor performance status? We'll just give you a few more seconds and then we'll get some answers. We've got some new people who've joined the call, so do get involved in the polls. It makes it more exciting when we discuss it later. Okay, so that's really interesting. So this time nobody's gone with combination immunotherapy with ipilimumab and nivolumab. Interesting, we'll debate it. I may well have done combination immunotherapy, and I'll be interested to see what Joe would have done later. Half of you would have gone with dabrafenib and trametinib. You know, I think that's a fairly safe choice. We've got a lot of experience with those drugs. A third of you would have gone with encobini. So again, I think that's very reasonable. And some of you would have gone with best supportive care. That's probably the only one that I definitely wouldn't have gone with. As long as you've got a pulse, I'm happy to give treatment in the BRAF mutated patients. And Joe knows this. You know, we are very aggressive if someone's BRAF mutated. As long as they can swallow, and even if you have to dip it in yogurt and get them to swallow, I would. So I probably wouldn't do best supportive care, and I probably wouldn't go with single agent pembro, but we'll talk through that. And then final question is an adjuvant case. So 65, a fairly thick ulcerated melanoma, had a sentinel node biopsy, 2 out of 4 nodes were positive and they were removed. Had a CT head and tap. We routinely do CT heads because, as many of you will know, about 20% of melanoma patients will get brain mets. Again, V600E mutated, so the most common mutation. So a relatively high stage 3, so 3B, LDH, normal. What would you do in terms of adjuvant therapy? So let's throw some options. Would you just put them on surveillance and actually say, look, this is only stage 3B, let's not give you adjuvant therapy? Would you recommend this patient went on to have all those lymph nodes removed? Would you give dabrafenib and trametinib, which is routinely given in this setting? Would you give single agent nivolumab, or would you give single agent pembrolizumab? Okay, and so nobody would give pembrolizumab. A couple of you would give nivolumab. So that's interesting. I wouldn't give nivolumab, and I'll talk about why a little bit later. Dabrafenib and trametinib, I think, is a very reasonable choice here. And I probably wouldn't do a completion lymphadenectomy based on some of the data that was presented at ASCO in 2017, which we can talk through. So I think that was quite interesting. Let's talk through some data. Let's talk through how we approach metastatic and adjuvant disease. And then very happy to take some questions, and we can debate some of those scenarios at the end. I'll just let my PowerPoint catch up. Okay, so let's think about metastatic melanoma. So as I said, things have moved on quite a lot over the last few years. We've gone from essentially some chemotherapy to a number of treatment options which have been put into those answers. So I tried to summarize this, and I did this a couple of days ago. So I tried to summarize how I would approach someone who comes to clinic and sees me on a Thursday morning. So when I'm seeing someone with stage 4 metastatic disease, I'm looking at the patient's fitness. So when I'm thinking about patient fitness, I'm thinking about other comorbidities. I'm in particular thinking about autoimmune comorbidities with the IO toxicity hat that Joe and I wear. I'm thinking about you know, how keen that patient is on different treatment options, particularly when I'm weighing up combination versus single agent immunotherapy. So I'm weighing up 60% response rates in the Ipi-Nivo trial versus, you know, 30 to 40% response rates with single agent Nivo or Pembro. And then with the BRAF MEK, I'm weighing up a slightly higher response rate with dabrafenib and trametinib versus slightly better PFS and OS survival with encobini, and a slightly different toxicity complement for each of those combination treatments. I'm thinking about dosing schedule. So some patients don't want to come to hospital very often. Pembrolizumab is 6 weekly. Joe and I don't use any 3 weekly Pembro. So clearly 6 weekly Pembro is an advantage in terms of less visits, less impact on that patient's life. And then in terms of toxicity, clearly combination Ipi-Nivo has got not just a higher rate, but a higher rate of many side effects coming together, versus pembrolizumab, where, you know, grade 3-4 toxicity rate is about 10 to 15% in trials, and I would say in reality it's about 10%. And as I've said, BRAF status important. About 40% of patients will be BRAF mutated, with again V600E probably having the best responses, some of the atypical mutations having much lower responses. So that's kind of how I would approach that patient. Maybe if we look at some data, and again, I don't present much data in talks. I do. Data's boring. It's boring even for medical oncologists, but I think you need to have a little bit of data to inform the decision making. So it's almost impossible to do medical oncology without talking about Checkmate 067, the pivotal trial of combination immunotherapy with Ipi-Nivo. Looking at the Ipi-Nivo arms weren't powered to compare against each other. So this is really a comparison of both of them against Ipi, but inevitably we do compare the two arms. And so this is the take-home data from that trial. So what are we seeing? We're seeing response rates of, as I said, about 60% in the combination. We're seeing response rates of around 40 in real life to Nivo, and Ipi about 20%. If you look at that long-term survival curve at 6.5 years, we're looking at around 50% survival at 6.5 years. But actually, once you get to 3 years, your chances of dying from melanoma are relatively low. You're allowed to die from other things. We've all got to die from something. And so there is a benefit between combination and single agent in terms of overall survival. But there is also the fact that there is this increased toxicity rate. Again, I would quote to patients a 60% grade 3/4 for combination treatment, a 10 to 15% toxicity rate for single agent. So absolutely need to be factoring that in to the decision-making process. And this is important data, and this is data that BMS don't really present as often as I think if I was BMS, I would present, which is actually that BRAF mutant patients do better with immunotherapy than BRAF wild type patients. And again, it's interesting, there's been an email trail that Joe and I have been in today about a patient who is BRAF mutated and what we're going to do with that patient. And that's why I thought it was quite interesting that when we looked at that poll, Ipi-Nivo had no one that was really interested in giving Ipi-Nivo to the BRAF mutated patient. But actually, if someone's BRAF mutated, I am much more keen to give Ipi-Nivo than I am to give single agent if I'm not going to give BRAF targeted therapy. And the reason for that is because of this data that suggests that actually if you're BRAF mutated and you're not getting targeted therapy with tablet treatment, actually I would argue you probably should be getting Ipi-Nivo unless there's a real reason based on fitness that you're not eligible. So again, interesting when we pose that question that Pembro was favoured over Ipi-Nivo, but in my clinical practice, Ipi-Nivo would be favoured for those patients. But I can't give a talk about IO without talking about toxicity, and hopefully many of you have joined some of the toxicity webinars that a number of us have been involved in. So this isn't an IO toxicity talk. I know some of you joined the talk that Anna Olsen-Brown and myself gave for the ACP 2 or 3 months back. But there are things that are important to note. So colitis, really important. Colitis is an Ipi-driven side effect. You can get it with anti-PD-1 or PD-L1, but it's really an Ipi-driven side effect. Endocrinopathies, as you know, tend to be manageable, but they tend to be also permanent in the vast majority of cases. Hypothyroidism being the most common, but about 1 in 500 patients get type 1 diabetes and end up on insulin. And so again, just thinking about that question I posed and the fact that so many people would have given BRAF therapy for that poor performance status patient, I actually think the conversation is a bit more nuanced than that. So when I'm seeing a patient, I would say to the patient, look, we've got the BRAF, you're likely to respond quickly. It probably won't be quite as durable as the IO response. And the nice thing about BRAF therapy is if I stop the treatment, your toxicity will normally resolve pretty quickly. If you get an IO toxicity, that's probably going to be lifelong if it's an endocrinopathy. And some of the other toxicities like colitis, you can end up with a colectomy and I won't be able to reverse that either. So actually, I think there's a really important conversation to have with patients around reversible versus irreversible side effects with these two different treatment modalities. And so there's also this discussion that says, well, IO, you stop at 2 years. And so actually that's great because if you get to 2 years, you stop the treatment and you get on with your life. Actually, Joe and I are maybe a little bit atypical from other oncologists. So neither of us do stop everybody at 2 years. We don't set everybody up to stop at 2 years. And actually, we have a conversation with patients at 2 years about, do they want to carry on? Do they want to stop if they've had a good response from the immunotherapy? And so again, I don't stop everyone at 2 years. And so that get to 2 years, we'll stop and life will be easy isn't my practice in real life. And so I would just say that BRAF versus IO combo conversation for the BRAF mutated is a little bit more nuanced than maybe it's been led to believe. And so there are a number of patients who are BRAF mutated and their poor performance status that I would still give IO combination if I thought that I had 12 weeks to get that on board. But again, it'd be great to have that debate. Management of immunotherapy, this is not the talk, but again, many of you will know that steroids is the answer as a rule. There's lots of data coming out for infliximab, vedolizumab, lots of other immunosuppressive agents. Again, happy to come back and give that talk another time. So, in the next 7 or 8 minutes, let me just talk a little bit about BRAF therapy and some of the data that underpins it. Again, like I said, I don't want to dwell on data. You'll know that BRAF targets the BRAF-MEK pathway, which is a driver for melanoma. We target the BRAF and MEK part of that pathway because we know the response rates are better. So you go from about 50% to 70% when you use the two drugs together, and it's actually less toxic. You get a lot less skin toxicity when you block both of those targets. And I've just tried to summarize the data really simply because, again, I get bored of showing lots of curves that are difficult to interpret. So this is how I think about it, rightly or wrongly. This isn't a pharma-driven meeting, so I can say, this is what I believe, which is the response rates, I think, for dabrafenib and trametinib are slightly better than encorafenib and binimetinib. That said, the PFS data and OS data is better for enco-bini. There's a little bit more brain met data for dabrafenib and trametinib. And again, we can talk a little bit about combi-MB if we've got time later. In terms of toxicity, dabrafenib and trametinib has a bit more pyrexia. I think it's fairly easy to manage the pyrexia. And I've just been involved in writing a document that basically says that you should stop both drugs. And that's what I do in clinical practice. I don't just stop the dabrafenib, I stop both drugs if someone gets pyrexia. Encorafenib and binimetinib is less pyrexia, but you do get some muscle aches, joint pains, which I think are a little bit more than I see in real life with dabrafenib and trametinib. So again, I don't think there's a simple answer to that. Enco-bini, a little bit easier. You don't need to work it around food, but it is bigger tablets. There are more of them. So again, slightly more nuanced conversation than maybe we're led to believe around which BRAF treatment to use. Final 5 minutes, just talk about adjuvant therapy. So again, how do I approach someone when I see them on adjuvant therapy? And I know many of you are going down the either dabrafenib and trametinib route, or you are going down the nivolumab route. So actually, I tend not to use nivolumab. The only patients that I would really use that is stage 4A because Pembro doesn't have a license there. But actually, if you look at dabrafenib and trametinib and pembrolizumab, I think they're much of a muchness in terms of the curves that we'll look at in a second. And again, this conversation for me is really about, what do you prefer, tablets or 6-weekly infusions? Do you prefer the risk of irreversible toxicities but rarer, or reversible but more common? In terms of reduction of risk, it's about a half reduction in risk, which I'll show you in a second. So I think that's comparable. I guess that the final conversation that I have around this discussion about which one to choose, certainly I've got colleagues around the country who would say that they always give dabrafenib and trametinib because it gives you 2 bites at the curative cherry in terms of trying to cure them with D&T, and if that fails, give an IO. I think there's some truth in that, but I still think if you fail on Pembro, there is a group of patients you can rescue by adding in the CTLA-4 with ipilimumab. So again, not an easy discussion, but for me, this discussion is really about patient choice and preference of IV versus oral. What does the data say? So if you look at the survival rates at 5 years, this is what we quote in clinic. So, if you've got stage 3A, you've got about a 90% chance of being alive. Improve that by 5% to about 95 with a year of adjuvant therapy. If you're in the stage 3B, you've got about an 80% chance of being alive. That we can take that up to about 90. So again, 50% reductions each time, 70 to about 85. And the stage 3D are really high risk. So, you know, about 70% of them will relapse. And I would be strongly recommending that we treat all of those with adjuvant therapy. The Pembro versus D&T, which is really the conversation I'm having in clinic, comes down to toxicity and patient preference. And this is just the data, just the top line data. And again, really showing that the hazard ratio sits around 0.5, which is why for ease, we talk about reducing the risk by approximately 50%. And then finally, in the adjuvant discussion, the two other things that come up, you know, do we do lymphadenectomies? Not as much, because we've now got adjuvant therapies that are effective. There was something called the NSLT2 study back in 2017, which looked at basically completion lymphadenectomies versus close observation with ultrasound, which we don't do in real life clinical practice, and showed that there was no improvement in overall survival. That said, it was quite a low risk group that were being looked at. So it does inform our decision making, and we don't do as many completion lymphadenectomies anymore, but it's not quite as straightforward as that trial gave us all the answers, because it didn't. What about the radiotherapy question? I don't routinely give adjuvant radiotherapy to melanoma patients, again, because it doesn't improve overall survival. It does reduce the risk of local relapse. The caveat to that is we do give adjuvant radiotherapy in some patients who've got high burden of disease and in the head and neck region, because again, if they relapse, you know, they can often affect nerves or bones, and so, you know, that's a real problem for the patient. And so there's a discussion that's had with my head and neck radiotherapy clinical oncology colleagues, and we do it on an individual patient basis in reality. So final 3 or 4 minutes just to take on some of this, and this may come up in the discussion after Joe's talk. How do we manage mucosal melanomas? Well, we basically manage them the same way. BRAF and KIT mutations only occur in about 10% of patients. So c-KIT, you can use imatinib. In reality, patients have to pay about £100 because it's not NICE approved. In reality, Joe and I will probably, you know, chip in and get that sorted somehow for the patient. BRAF, again, about 10% will have a BRAF mutation, so less common than cutaneous. And when I talk to patients about IO, immunotherapy in mucosal, I really quote two-thirds of the response rate and 2/3 of the overall survival rate that we see in cutaneous melanoma. So not quite as good as we see in cutaneous, but not as bad as we see in ocular. So ocular melanoma isn't very UV driven, so it hasn't got a high tumor mutational burden. We use immunotherapy. Again, it differs across the country. Some people just use single agent. Some people use combination. If they're using single agent, I tend to use IPI because it's 4 cycles and there's not much difference in terms of response rate between IPI and Pembro. Response rates are less than 10%, and these patients tend to do poorly. There is a drug called tebentafusp. I can barely pronounce it. It's going through the approval process at the moment. It works in a slightly different way. So it works based on a HLA 0201. So about 50% of patients have a particular HLA subtype of their melanoma which responds to this drug. It basically works by binding to that receptor and then recruiting T cells. The data's okay. So the response rate is still less than 10% in the trial, but there is about a 5-month improvement in overall survival. So it probably has a role. It's probably the best thing we've got on offer for ocular melanoma for now. But again, waiting to see where we get to with the NICE process. There's often a discussion around sequencing of IO versus BRAF. And again, that kind of was alluded to in the questions. I don't think we know the answer about the best way to sequence them. There is some data in the DREAM sequence trial, and there's some data from Secombit. DREAM sequence is looking at, do you start with D&T or do you start with IO? Secombit was looking at Encobini versus IO versus 8 weeks of Encobini and then on to IO. the upshot of the story is, if you look at dream sequence, overall survival at 2 years was 20% better in the BRAF group when you started with BRAF. And to combat, again, there's a trend towards an improvement in survival. At 3 years, I think it was 62% were alive in the Encobini arm, 54% were alive in the Ipi-Nivo arm, and 60% were alive in the sandwich arm, where you gave 8 weeks of Encobini and then switched. So what do I take from that data? If it probably makes sense to start with immunotherapy if you can, if you've got time to do that. And that's why it was interesting to see that nobody went with Ipi-Nivo for that poor performance status patient, but actually using this sequencing data, I think it'd be very reasonable to give them Ipi-Nivo if they were stable enough. Where is chemotherapy nowadays? We don't use very much of it. It's a last line therapy. Joe and I do use chemotherapy though. I know some centers don't. And we tend to use either dacarbazine, which has response rates of 10 or 15%, or if someone's super fit, we give them dacarbazine with cisplatin based on response rates of somewhere between 20 and 30%. What's coming down the line? So we've got that relatlib drug, which is, I'm going to call Rela because I can pronounce it. And so Rela, there's a trial called Relativity 047, which is basically looking at the combination of Rela with Nivo. Georgina Long presented an update after the last ASCO. In essence, the response rate is about 40%, which was better than single agent Nivo. There was some improvement in PFS and a trend towards improvement in overall survival. PFS 10 months versus about 5. I think its role is going to be in patients who aren't fit enough for Ipi-Nivo, but again, it's not NICE approved, it is FDA approved. And I think later this year, we're probably going to have Pembro for stage 2 disease, which will be a whole world of pain in terms of trying to find clinic slots for them, but clearly will be great for patients. And there's another drug called Lifalusil, which is a TIL therapy, which again, isn't quite ready for prime time yet. And then finally, the final thing would be brain mets. We've got data for Ipi-Nivo, primarily showing that if you're asymptomatic, response rates are about 50% based on the ABC Georgina Long trial. If you've got symptomatic disease, I would tend to go with BRAF if they're BRAF mutated. And again, that's the COMBI-MB trial, similarly about 50% response rate. But despite that quite encouraging response rate, PFS is about half in real life to what we see in non-brain disease. And if you can treat it with radiotherapy, I think that's preferable. So that's a bit of a whistle-stop tour of melanoma. I will stop there just to say, and hopefully many of you already know about this, that once a month on a Thursday, so the first Thursday of every month at 1 p.m, regardless of what date that falls on, there's a national immunotherapy education meeting that myself and Helen Winter from Bristol co-chair. I know many of you already join it. It's completely free of charge. It's completely non-promotional. We discuss complex cases with anonymized patients. We discuss research and audit. And it's great to get trainees to present at it. So please do drop me an email afterwards if you want to be added to the distribution list. It originally was a Southwest meeting. It's now a national meeting, and we're going to be launching it formally as a national meeting the first Thursday of September. So please do get in contact with me if you don't know about it, but yourself, TNSs, trainees, anyone is very welcome to join as long as you've got an interest in immunotherapy and toxicity management. I will stop there. I'm happy to take questions now or happy to hand to Joe and we can do questions later.
Thank you very much, Ricky. That was an excellent presentation. Thank you. We've had a few questions through, but it'd be great if people could post questions on the chat if you had some for Ricky. And I'd also like to invite Joe Ocen to the discussion as well. One of the questions from Alistair, which you did touch on this, just said, "Hi Ricky and Joe. Has dream sequence data influenced your decision making for Ipi-Nivo versus targeted therapy as first line?"
Yeah, I think that's a really excellent question, Alistair. So has it influenced things? It's in the back of my mind is the honest answer to that question. So, you know, it probably hasn't changed what Joe and I do a great deal, because Joe and I have always, and I don't want to speak for Joe, but we do our joint clinic, so we tend to give IO if we think we've got time to give IO, and I don't know the data, but I'd imagine Joe and I probably prescribe more combination IO than most centres, and that's certainly the feeling I get at national meetings. So I think we were already giving Ipi/Nivo as our frontline option, unless someone's in absolute extremis, and then we would tend to give BRAF. I guess the reason why Dream Sequence hasn't influenced us that much is because there is actually still the conversation with patients. And so I will always put to patients that, what's important to you. So I will give IO combo if I can, but if a patient says to me, actually, I don't particularly want to come to hospital, I'm worried about toxicities, I don't want to risk having permanent side effects, I think putting all the data aside, patient choice still has to trump the data. And so I'm still very comfortable giving BRAF direct therapy as long as the patients are fully informed of the top line data, but their priority is quality of life. And some patients will often say, look, I don't want to live forever. What I do want to do is live for the next 12 to 24 months with a good quality of life and get to my daughter's wedding, in which case I will very confidently go straight in with BRAF rather than IO. But Joe, I don't know if there's anything you want to add to that.
Yeah, just to back up what you said, I think that is a really good question. I think it just backs up what we do. So it's quite nice to have that data there when often patients do ask that. Many patients are quite well read. So I had a young chap the other day that asked about Bini and Carafenib, and it was quite useful to use that data to explain, data to explain why I would recommend immunotherapy first of all, because this was a fit young man, and just where possible, if the patient is fit enough, I'll be keen to explore first-line immunotherapy. Of course, as Ricky says, it is the patient's choice, and it's obviously down to them once they weigh up the risks and benefits of both treatments. I do say that there is more chance of more durable response with the combination treatment, and it just basically backs up what we do anyway, I would say.
And Jodie, just before we come in, because I guess just one thing I didn't present in view of time is, we shouldn't forget as well that you get durable benefit from BRAF therapy. So, we've got 5-year data now with BRAF therapy showing that 20% of patients are still progression free and a third of those patients are still alive. And and I lead this in because the next question is about biomarkers. So someone who's got a normal LDH and less than 3 sites of disease with BRAF has almost a 50% chance of being alive at 5 years. And so actually this kind of durable IO response, which is true, is also true about BRAF. And so I've got a number of patients who have had BRAF and are 4 or 5 years down the line. They've never had the risk of IO toxicity. They're taking tablets, they're not coming to hospital. And so I think we just have to be a little bit careful that we don't forget about the 5-year data that we've got for BRAF therapy.
Okay, great. Thank you, Ricky. So the next question that we've had in the chat was, hi, Ricky, other than LDH, are there any other biomarkers that you use in clinic for treatment selection? Neutrophil to lymphocyte ratio in IO, for example, or are there any biomarkers that you think may have promise in the future?
Yeah, I think that's a great question. So, so I don't use neutrophil to lymphocyte ratio in IO. I think there is a lot of work coming through on that, and particularly in renal cancer, there's quite a lot of coming through on the neutrophil to lymphocyte ratio. So I don't use it. What I do think will end up getting prime time at some point is tumor mutational burden. So there is obviously the PD-L1 story, which definitely there is something in melanoma with PD-L1, but we don't routinely test it. I think tumor mutational burden will be important. I think the microbiome story is really interesting. So, I do think at some point, we're going to end up giving people like bifidum bacteria to try and stimulate an immune response and make the immune environment more favorable. Obviously, we've got the MITRE study in melanoma. There's some really nice data in renal looking at CBM 588 and looking at the way that enhances the immune response with Ipi/Nivo. So I think that's where most promise is.
Brilliant, thank you. And just before we move on to the next talk, for your second question that you posed in the 72-year-old that was symptomatic with metastatic BRAF mutated melanoma, what would have been your option and how would you treat this patient?
So when I saw that patient, I discussed ipi/nivo with them, and I discussed abraxane and trametinib with them, and we ended up giving ipi/nivo, which is so the conversation would have been, I would have said, look, you know, I think that at the moment you're teetering on the edge of someone who's declining quickly. I think if I can start you on ipi/nivo within the next 2 or 3 weeks, I think we should do that. And as Joe knows, this is the sort of patient that we will see every 3 weeks face to face, and we'll probably end up asking Jodie or one of the CNSs to ring this patient weekly or 2 weekly. And as soon as I think that they are going in the wrong direction clinically, I will pull them in and start them on one of the BRAF therapies.
Great, thank you very much, Ricky. Brilliant. So I now have the pleasure to welcome and introduce our second speaker of the evening, Dr. Jo Ocen, who is also a medical oncology consultant at Velindre Cancer Centre. So Dr. Ocen is a specialist in breast and skin cancer and has an interest in acute oncology. She's also an honorary lecturer at Cardiff University and is in the process of setting up an immunotherapy toxicity service with Dr. Ricky Frazer for South East Wales, which will launch later this year. So Dr. Ocen, when you're ready, over to you. Please go ahead and share your slides.
So thank you very much for having me. And so I'm Jo Ocen. I'm a medical oncologist in Velindre Cancer Centre, and I have the pleasure of and honour of working with Ricky Frazer, one of my really good friends and someone I look up to very much, very knowledgeable. And it was quite interesting seeing those cases that Ricky had brought up, and often the good thing about running our joint clinic together is we have these conversations about what we would do. So it's quite good to explore it again today. So I've been invited today to discuss managing metastatic Merkel cell and squamous cell carcinomas. It's not as meaty a topic as melanoma, but what I'll be doing is talking about briefly the background of the cancers, how we manage them, and toxicity management. Feel free to ask me any questions. Happy to take some questions at the end. I'll also be discussing a couple of cases with a couple of polls. So how I will do it is go through into a case, take an initial poll of what you would do, how you would intervene, then go through the data, then revisit the question and see if your minds are changed after going through the data and best practice. So the first topic I'll be covering is Merkel cell carcinoma. So this is a very exceedingly rare tumour, and it is in the family of the neuroendocrine tumours. So it's very rapidly progressive, very aggressive cancer that acts in a similar vein to a small cell lung cancer, for example, and other more aggressive neuroendocrine tumours. And in the past, we would have used treatments similar to small cell cancers and other aggressive NETs. The way it looks are these kind of very fleshy, nodular, violaceous nodules that are characteristically grow very quickly and rapidly within weeks and months. They usually they present on sun-exposed areas, so obviously the face, limbs, back, and neck areas. In terms of risk factors, 80% are associated with a particular virus called the Merkel cell polymer virus, which is thought to be involved with the malignant transformation into the Merkel cell cancer. It's also associated with patients that are immunocompromised. So whether they're suffering from an immunodeficiency syndrome such as HIV, or if they're compromised from immunosuppressants, because they have taken them for their organ transplant, and also associated with patients with a history of hematological malignancies such as leukemias and lymphoma. The Merkel cell is situated in the basal layer of the epidermis, as shown on the diagram here. And in terms of the pathogenesis, it's not still clear about the etiology of the Merkel cell. So there's a couple of theories surrounding the pathogenesis. So one is that it is just a malignant transformation of the Merkel cell itself, which is quite controversial. And another theory is that it's the malignant transformation of an immature stem cells within the epidermis that develop neuroendocrine tumor features then giving rise to the Merkel cell cancer. So there's still quite a bit that's not understood about it, but this is, these are how they present. So a rapidly progressing, quickly growing violaceous nodular tumor in a sun-exposed area. Think of Merkel cell. So the vast majority do present as a primary disease only, so just over 2/3. About 25% of patients, according to data, can present with local or regional disease, so with local lymph nodal involvement, and about 10% of patients, 10 to 15%, can present with distant metastatic disease. With these patients, if they go on to have early disease and it's resected, unfortunately there is a very high risk of the Merkel cell recurring. So that is always worth bearing in mind. And so unfortunately that can lead to quite poor prognosis. So on average, patients with Merkel cell cancer, about 10 to 20% of patients are alive at 5 years. So it's quite poor prognosis, really, particularly for more locally advanced or metastatic presentation. So how we optimally manage early stage operable disease is surgical resection where we can. There is a role for adjuvant radiotherapy. There have been some limited observational studies that have looked into the benefits of radiotherapy, and it does show that it can significantly reduce the risk of recurrence, local recurrence. There's not a lot of strong data to suggest that radiotherapy obviously reduces the risk of overall survival. At the moment, there is no indication for any systemic therapy, adjuvant systemic therapy after the tumour has been resected with either immunotherapy or chemo. Okay, so this is the first case. So it's just a rough poll to see how you would manage this patient. So this is a lovely man of mine, very fit man, although he's in his 80s, with no comorbidities or regular medication, diagnosed with a Merkel cell over his scalp and the left side of his neck, so a locally advanced Merkel cell, really. And it was a rapidly growing tumour, so by the time he presented to us, unfortunately, to the surgical team, it was too far gone for surgery. So if we did a CT scan which didn't show any distant metastatic disease. So my question is, what would you think what would be your first choice for first-line treatment? So would it be radiotherapy, Velindre, carboplatin etoposide, cemiplimab, or topotecan? So a quarter have gone for radiotherapy, 60% have gone for Velindre, and 13% have gone for carboplatin etoposide. So we'll come back to that question in a bit. So this is just one of the first slides for data. So it's the Javelin trial. So it's looking at, so this is from about 3 or 4 years ago, I believe. So the first trial was a phase 2 trial, 88 patients, looking at the role of investigating the role of velindre in patients that were not chemotherapy naive. So they would have had 1 or 2 lines of treatment. And the primary outcome was looking at the response rate, and a secondary outcome was looking at the duration of response. So this trial showed some promising data in a group that was previously treated, and the response rate was about a third, with a complete response rate of 11% and a good partial response of 22%. And you could just see on the Kaplan-Meier curve that a third, just actually more than a third of patients are alive at 3 years on, so 32%. So it's really changed the game, as it has with melanoma, in terms of obtaining a durable response in these group of patients. This is the Javelin trial, looking at patients with who are receiving this in the first line, so treatment naive. And this is obviously a larger cohort. And we saw a greater response rate in these patients, and with a median overall survival of about 20%. So again, the durable response is really good, with about quite a long durable response. So probably looking at 75% at 6 months, then 60% at 12 months. So yeah, so that demonstrates that really well. In terms of adverse events, so in terms of the toxicity profile, it's pretty good actually. So in terms of the main treatment related adverse effects, and generally fatigue and pruritus were the most common adverse events in terms of immunotherapy related adverse events. About just under a third of patients would have some kind of toxicity at any grade. And in terms of those types of immunotherapy related or immune mediated side effects, that these immunotherapy drugs are well known to produce pruritus and rash and dermatitis and psoriasis like illness was associated with these drugs. But with the cemiplimab, again, the side effect profile is not too bad. And in terms of severity, only 6% of the patients in the cohort had a severe side effect. So we do tend to see this in my practice, and with Ricky as well. These patients tolerate cemiplimab really well, even in comparison, dare I say, to patients receiving immunotherapy for melanoma. We have many patients that are a bit frailer, older, many in the 80s, the classic kind of patients, more frail patients, and they tolerate these drugs very well. I believe one of Ricky's lovely, delightful patients in her late 80s has been on this drug 2.5 years, and she's tolerated it very well and had an amazing response, almost complete response, I believe. Bill Ricky can correct me later on. So we do see that in our practice as well. So I don't want to go over this too much. This is just a reminder of the mechanism of action. So in terms of, sorry, I don't think it translated well on my slide. So basically it's looking at the interaction of the ligand, so the PD-1 ligand from the T cell membrane interacting the tumour cell after the antigen has been presented to the T cell. So with the PD-1, that this is basically a regulatory effect to keep the T cell in check, to keep it inactive. And this is our normal regulatory process that we have to keep our T cells behaving themselves. So our monoclonal antibodies, so the PD-1 and the PD-L1 inhibitors, basically inhibit these ligands to activate the T cells and prime them to cause apoptosis and cell death, tumor cell death. So Velindre is an example of a PD-L1 inhibitor, and PD-L1 inhibitors are the nivolumabs and cemiplimab, which I'll talk about in a bit. So again, similar slide to Ricky, when we're counselling and consenting our patients, we really do need to make it clear that immunotherapy can induce these immune-mediated reactions in any part of the body. It's a very important part of education to keep our patients safe. And of course, if we strongly urge them to call us if they have any issues at all, as we know that immunotherapy can cause some very odd and very weird immunotherapy mediated responses, ranging from, I had a patient, for example, who had newly induced diabetes ketoacidosis. So we developed new type 1 diabetes on a PD-1 inhibitor. And so he presented with drowsiness, and he also presented with pneumonitis, which is a less than 1 to 3% incidence. So it's really important as part of education to warn our patients if they feel unwell in any way. It could very well be the immunotherapy drug, and obviously this will be something that we are working towards in our immunotherapy toxicity service, education, and also, of course, supporting the management of these toxicities in our patients. So how we have our systemic immunotherapy clinics where we closely monitor the patients. We have a safety net of an urgent helpline for our patients to call in, whether they present. So we work in a cancer centre, and so our patients are often present to our local health boards, and so they're not as, the medical teams or surgical teams or whoever's looking after them are not as familiar with immunotherapy. So it's very important that we have these close links with our health boards and specialty colleagues for education's sake, and also to make sure that the management of these toxicities is consistent as possible. So basically the traffic light system. So we are currently we're currently updating and revising our guidelines, and so these obviously widely available for not just oncology colleagues but our non-oncology colleagues as well. And so it ranges from mild to moderate to severe. So mild, we'll just monitor. Moderate, we would think about systemic steroids with oral prednisolone, for example, omit the treatment and see how things go. Think about restarting if the symptoms or the side effects have resolved. For some more severe side effects, so grade 3, 4 side effects, we would have to admit the patient, intravenous steroids, and obviously get specialist input depending on the type of toxicity. And we would have to stop the immunotherapy, particularly if it was severe or life-threatening. So going back to my man, so we already did the poll. I think I'll probably skip that, but I'll just go through the various choice for first line. So in terms of the first line, technically we could use the first three, so radiotherapy, Velindre and carboplatin. So the radiotherapy we could use in conjunction with the systemic therapy. With this data, with the Velindre, this has really superseded the chemotherapy, particularly in this patient cohort, which tend to be older. So I think the average age of patients at presentation tend to be in the median age of about 70. So chemotherapy really would present a lot of risk and may even cause them to develop life-threatening side effects from neutropenic sepsis, neuropathy, etc. So I would tend to use avulimab. In this case, with our man, we did use avulimab and some radiotherapy. And we are seeing that not just with avulimab, but with skin cancers in general, the combination of using radiotherapy with immunotherapy for locally advanced disease to get really good local control. In terms of atezolizumab, obviously that is not indicated for Merkel cell. Topotecan, technically we can use that for these type of neuroendocrine aggressive tumours such as Merkel cell, and of course with small cell cancer, but we would tend to reserve that as more of a second line. That's personally what I would do. So just more of what I've just said, basically. So it's quite straightforward. There's not really much to it in terms of managing metastatic avulimab. Metastatic Merkel cell. So avulimab is our first line at the moment. Chemotherapy, if they're fit enough and want it, would be more second line. Obviously, in terms of immunotherapy, some of these patients can have history of organ transplantation, and they are on immunosuppressant drugs. And so we'll talk about that towards the end of the presentation with one of the cases, but that is something worth bearing in mind. And it may be that we have that discussion with the patient and we go with chemotherapy if we thought that immunotherapy was not was contraindicated. There's always a role for local radiotherapy for these patients, like my chap. And we have got, sorry, this is the wrong one. So with second line treatment, we have got the carboplatin etoposide, topotecan as a second line, like I said, with the chemotherapy responses. So as with any neurocrine or small cell like cancer, we do see quite a lot of chemosensitivity. So there have been some various observational studies that have reported response rates of about 20 to 60%, but these aren't very durable. So this can, in terms of length of response, it's less than a year really, so 3 to 9 months. In terms of so it's not as durable as we would see from immunotherapy. In terms of the chemotherapy toxicity, like I said before, that's something that needs to be considered if a patient is going to have second line treatment. So I'll just move on to metastatic squamous cell carcinoma. So it's a bit more common than Merkel cell. So it's almost 80 and 100,000 incidents between 2013 and 2015. Usually has a very good prognosis if caught early and resected, with a 5-year overall survival of 95%. Less than 5% go on to develop local regional metastatic disease. In terms of risk factors, again, it's sun exposure, Caucasian skin, HPV, interestingly enough, similar role in the head and neck cancers, and immunocompromised patients, of course. So patients, often we see these patients they often have history of being on immunosuppressant drugs for the organ transplantation. So that always adds an interesting and challenging dynamic when deciding what treatment to go for. In terms of adjuvant radiotherapy, it is indicated for what is deemed high-risk disease, poorly differentiated recurrent disease, and local regional involvement. And of course, there is always a role for high dose or palliative radiotherapy for inoperable disease. So the first case we have is a 58-year-old man. So this is quite a sad case for me. He presented, so he was referred to me by one of my head and neck colleagues. So I think it was a maxillofacial surgeon actually. And he knew this patient very well. So this patient had a history of renal transplant onto immunosuppressant drugs. He had, over the years, had multiple recurrent squamous cell cancers. And he had extensive surgery for this with extensive grafts and radiotherapy. And unfortunately, where he had the cancer in the neck, he had a lot of radiotherapy, and as a result of that, it did damage the trachea, leaving him with a lot of secretions and impaired swallow, therefore making him very susceptible to chest infections. And when I was seeing him, when I was referred to him, he was actually an inpatient with aspiration pneumonia. And his swallow isn't safe, and his airway wasn't very safe either. So there was a lot of, I think the ENT team wanted to see how things go, and they weren't particularly keen to put a tracheostomy to secure his airway. So things were very basically on tenterhooks, really. So it was quite a challenging case. So unfortunately, this man, while he was having a lot of back and forth with recurrent hospital infections, he was diagnosed with another locally aggressive recurrent disease. And sadly, this time, the surgeon couldn't operate, and he was referred to me. And so I think radiotherapy wasn't an option either. So this is the second poll. So with that in mind, with all that complex history, what treatment or intervention would you offer to this gentleman? And this was a man who was very desperate for treatment, but it was just very difficult, because obviously we had to think what was more at threat: his recurrent respiratory infections, impaired airway, or the skin cancer. I thought it was the latter. So would we think about carboplatin, paclitaxel, capecitabine, or cisplatin, cemiplimab, cetuximab, or watch and wait with quick interval surveillance? So 86% went with cemiplimab, and 14% went for cape and cis. So yeah, those were sensible options, but we'll talk about that more in a bit. So with cemiplimab, so this is something that's been relatively quite new. So we've been using the last couple of years, I believe, for inoperable, locally advanced inoperable disease and metastatic disease. And this, in terms of the data, it did show. So I'll talk about the data in a bit. So there was 2 trials, I believe. So there was a phase 1, small number of patients, about 26 patients, which showed an overall response rate of 50%, which was really good. And then they went on to have an open label phase 2 trial. Sorry if you hear my dog, apologies. So this is the larger study, so the phase 2 open label study. And basically there are 3 cohorts. So we're interested in the metastatic cutaneous squamous cell, and basically patients were given 2 dose regimens. We currently obviously are using the flat dose 350 as a result of the trial. And so again, promising results with the objective response rate of over 40% were seen in the metastatic group, with a duration of response of more than 6 months, of I think about in the region of 15 to 20%. So in terms of the, again, similar to avelumab, we are seeing more durable responses compared to what we would have seen with the chemotherapy. So in terms of adverse events, patients are tolerating this well. I see this not just in the data, but also in real life data as well. Our patients tend to be older and frailer, and it could be just because their immune system isn't as lively as the younger patients, hence why they tolerate the treatment pretty well. But as the data shows, it's quite rare for patients to have a severe side effect. So the most common effect we saw was fatigue, really, with some skin toxicity. So this is the Kaplan-Meier curves, basically, the obligatory Kaplan-Meier curves showing progression-free and overall survival probability. So with the progression-free survival probability is about 40% at 24 months, and overall survival at 24 months is about 73%, which is pretty good. In terms of other treatment lines, chemotherapy was the mainstay for our metastatic patients. So it would be a capecitabine or a platinum treatment, carbo or cisplatin, or we would think about carbotaxol. There's not a lot of data on this, so it's more pooled observational analysis. But with what I saw, there was the overall response, the response rates, sorry, I think that's a mistype there. So the response rate was probably looking at about 18 to 19%, overall survival was about 15%. In terms of other types of treatments, there are some data here with cetuximab, very small, again, study. So one study I saw, the largest study I saw was a phase 2 looking at 36 patients. And the response rate wasn't too bad, about 28%, but there was a lot of toxicity, unsurprisingly with acne, foam rash, and GI toxicity infection. As we see, the response rates aren't as durable, and the adverse events and toxicity from the chemotherapy and the cetuximab EGFR inhibitors can be pretty toxic, and we have to think about these patients, how that fits with our group of patients that tend to be a bit more frail. So basically, I won't do the poll for this one. It's just really a general discussion, which we can probably have with Ricky and the floor in a bit. But in terms of what intervention we would offer, so I guess the options would be rightly so, cemiplimab, capecitabine, or cisplatin. A watch and wait, because this man was very unwell, would be another option personally for me. I wanted to see what the extent of his disease was doing. He was only just discharged from hospital, I believe, the day before, and I would have just been keen to see how he would do, maybe not waiting the whole 3 months or anything like that, but waiting a few weeks just to see if he became fitter, and also to see what the outcome would be with his airway, and if there would be, I would be keen to see if there was any, if the ENT or maxillofacial surgeons had an opinion about how best to manage your airway with tracheostomy, as this would be an ongoing problem. And of course, with this cemiplimab, there's a problem with his renal transplant. So with this man, I had a very proactive renal physician that got in touch with me actually when he heard that he was being referred to me, and we had like an hour and a half discussion about this chap. He obviously knew him from when he was first diagnosed with the renal failure, and we were just going through the pros and cons, and he took liberty to also do some reading about it. And there was a few case reports, there's not that many, with patients with receiving immunotherapy with renal or organ transplant, and it's not contraindicated, so we would be right to consider this, but we also have to counsel, and that was something I made clear with the patient when I met him, that the renal transplant could fail on immunotherapy. So we're really stuck in a really difficult place, really. So this man, with the physician, the renal physician, was already starting to wean his treatment, his immunosuppressant drugs down, before I even spoke to him. So he was very proactive, and we made the decision to consider starting him on cemiplimab. I wanted to see him 2 weeks later, but it's quite a sad case. Unfortunately, his airway was very unstable, and he ended up passing away, unfortunately, from not his cancer, but the complications from his previous treatments, his impaired airway. But it is a dilemma that we are seeing more and more of, and as we're using immunotherapy more and more, and we're getting more comfortable with managing the toxicities, we can explore this and be more comfortable in starting patients on these drugs with such history. So in terms of just to summarize, for both these cancers, so Merkel cell and metastatic squamous cell, immunotherapy is usually first line, unless obviously there's a reason that they can't have it. But it's a case-by-case discussion, of course, and patient decision. There is a role for radiotherapy, usually in the adjuvant setting, and there is data for both types of cancer to show benefit of reducing local recurrence. Obviously, there is a role for it in the palliative setting as well. Chemotherapy is associated with poorer survival outcomes, and it is tolerated less well than immunotherapy, which we, like I said, we have to consider when deciding how best to manage these patients in a group that are meant to be quite frail and a bit older. So that's it for my presentation. Are there any questions?
Thank you very much, Jo. Again, another excellent talk, and thank you for sharing your experiences. I'd like to invite Ricky Frazer back just for the panel discussion as well. But I was just wondering what you would, regarding immunotherapy and patients with organ transplants on immunosuppression, and obviously you're saying that you had to counsel the patient for risk of rejection. Does it affect their response to immunotherapy if they are on immunosuppression for organ transplant? Is that why you needed to think about reducing the dose?
Yeah, so theoretically there is always that risk. Unfortunately, there's not a lot of concrete data to show that, but when I was doing some reading for this gentleman, the case report showed that I think about half of patients still did respond, but it's yet to be formally investigated, unless Ricky knows more. In terms of my practice, I don't have a lot of experience with this. I think it's very rare that we come across these dilemmas, but I think it's always worth obviously liaising with the specialist, whether it's a hepatologist or a renal physician, and having that discussion. And I have found that in a couple of cases that I've managed, and they are quite open to reduce or to completely wean down the immunosuppressant drugs. And it's about weighing up the risks and benefits and taking that decision with the patient.
Joni, maybe if I just add a couple of things, it's only really fresh in my mind because I've got a renal transplant patient starting next week, so so I've had to read the literature quite recently. So if you look at response rates for the squamous cell patients, you're looking at somewhere between 30 and 40%, so about 2/3 of the response that you would see based on the Empower data Joe's shown. Similarly, slight reduced rates in melanoma patients. And then the risk of renal transplant rejection is around 40 to 50%.
Right, okay. So it's quite high.
Yeah, so a high risk, so
it's
about
50%
of losing the organ and a reduced chance of response.
Okay, brilliant, thanks, Beth. Just Joe, going back to Merkel cell cancers, I was just wondering with carbo and etoposide, obviously you said this is quite a, tends to be older, frailer population. What are the sort of response rates in using that? You said you would use that, consider using that. Would that tend to be second line if they progressed after avelumab, or?
Right, in terms of the chemotherapy? Yeah,
in the chemotherapy option for Merkel cell, as you said, it was sort of, does it respond in the same way to a neuroendocrine tumor?
Yeah, so it is quite chemosensitive. So we are looking at response rates of up to 50 to 60% initially. But in terms of duration of response, the data shows that it's probably in the region of maybe 3 to 6, maybe 9 months at a push. So in terms of the chemotherapy, so it's about having that discussion with the patient, and if we're able to if they're feeling that it's worth the potential risk and they're well enough and they want a bit of extra time, then we can consider it. And I have done with metastatic Merkel cell in patients that haven't responded to avelumab, which is not very common, but yeah.
Thank you both for your excellent presentations. So but on behalf of the speakers and everyone at the ACP, thanks again and good night.